TopMedTalk.
Well, hello and welcome to TopMedTalk. We're coming to you live from Anesthesiology 2025, which is being held in beautiful San Antonio in Texas. It's the annual scientific meeting of the American Society of Anesthesiologists. This is day one, and we're recording in the middle of the afternoon. We've had a busy day, Andy Cumpstey.
Really busy day, but really successful day in this, quite frankly, massive exhibition hall that goes on as far as you can see into the distance, doesn't it?
It does. It gets you 1,000 steps up in like one easy morning tea break.
People were, literally whizzing around on motored scooters and bikes and then vanishing off into the distance. I think everybody must be here in America who's an anesthesiologist. There's people as far as you can see into the distance.
It's a huge meeting. We're very lucky, actually, to have snared one of the great speakers at the meeting, Susan Goobie. Welcome to the podcast.
Thank you. It's a pleasure to be here. Thank you for inviting me to speak.
Now, you sound like a Canadian, but you work in America. Can you give us a little bit of detail about yourself?
Yes, thanks for asking. I am Canadian. I have dual citizenship. I trained in Canada and Newfoundland, Canada. Born and raised, did all my medical school there and my anesthesia training. And then when I wanted to do a fellowship in pediatric anesthesia, I thought, why not go to Boston? I took a short stint to Vancouver, British Columbia, and worked on staff there for a while, but I've been back at Boston Children's Hospital now for about 20 years.
Wow. Do you specialize in any particular part of pediatric anesthesia?
I do. I do non-cardiac surgery. Clinically, I specialize in all the big cases that lose a lot of blood. So that will be craniotomies, a lot of neurosurgery, craniofacial surgery, big spine surgery, that sort of thing, trauma. So my area of expertise really has become blood management.
And you're giving a presentation about that at this meeting. Can you give a bit of a summary of what you're going to say?
Sure. Well, patient blood management is the topic that I'm speaking about. It's really become a passion of mine. Basically, what patient blood management is everything to do with blood health. So you've probably heard of like heart health, gut health, kidney health, that sort of thing, brain health. Well, nobody really ever speaks about blood health. And when you think about it, it is really an important organ. It's one of the largest organs of the body. It's a liquid organ, the circulatory system and all the blood it contains. And so I think it's a topic that people don't think about. And so what patient blood management is doing everything to optimize the patient's own blood health and in the perioperative space particularly. So I'm speaking at this conference as with my editor hat on. I'm talking about best patient blood management articles, but also talking a lot about what is blood health.
So what is blood health? When does it start and when does it finish in relation to the perioperative period?
Well, blood health is really three pillars. It's the preoperative, intraoperative, and postoperative phase. One of the major things that we don't think about is optimizing our patient before the surgery. Very often as anesthesiologists, we see the patient the week before the preoperative clinic and off you go, we send labs. And we often ignore the patient's blood health until the time is when they're coming for their surgery. So preoperative anemia management is really one of the first pillars of blood health. It's actually timely diagnosing and managing a preoperative anemia. And for me, being a pediatric anesthesiologist, it's particularly important because about 25% of our children who come for major surgery are anemic.
Is that right?
So it's a big modifiable risk factor.
So that is higher than in an unselected adult population. Why is that the case?
The World Health Organization has similar numbers for preoperative anemia in children. Mostly it's iron deficiency anemia, poor diets, honestly. And then also subsection of patients probably have anemia of chronic disease when we see them in the hospital. But anemia is often ignored. And we know that patients who are anemic, who come for major surgery, have a higher incidence of complications, adverse events, and a higher risk of blood transfusion. So it's one of the things that I've been talking about a lot is that somebody needs to own this, and we need to work with our surgeons and try to have timely diagnosis and management of anemia, which is 3 to 6 weeks before surgery. And I've been threatening many of my surgeons now because we have good guidelines that, your patient is anemic. I think we should postpone. And now they're getting the message.
So many things you've just said that I want to pick up on. Firstly, I love the term blood health. That's not something that I've ever heard before. It's never been mentioned in my UK training, but I think it's a fantastic concept.
Yeah.
And I love the pillars. In thinking about that preoperative pillar, I mean, one, an astounding statistic, but if that is such a high proportion of children, what are the interventions that we should be intervening during that period to try and bring that number down? And over what sort of time period do those interventions take to work?
Well, all of our guidelines recommend that it takes at least 6 weeks to properly diagnose and manage preoperative anemia. I bet it takes longer than that, but at least 6 weeks. And so usually, as I said, it's iron deficiency anemia. So usually just simply supplemental iron supplements will do the trick.
Supplements or intravenous, does that not matter? Or
most patients respond well to PO iron supplements. So improving their diet, infants with breastfed mothers supplementing in their diet with iron drops, older children, iron supplements, and iron-rich diet, those sorts of things, 2 times a day with orange juice, with food, different things like that. And we've found some good results. We have a protocol at Boston Children's Hospital called CHOWI, Children's Hospital Optimization with Iron, and the last is EPO. So our really high-risk patients, we will also give erythropoietin. And I brought that to our hospital because I thought, why do we do such a good job of managing patients where blood is not an option? We pull out all the stops. We give them IV iron, we give them erythropoietin to increase their red blood cell mass before surgery. So why can't we do that to our high-risk patients who are coming for big surgeries? So we've started this protocol where we're actually doing IV intravenous iron, depending on the timeline, and erythropoietin to not only treat anemia, but also to get that red blood cell mass up beforehand. But usually 3 to 6 weeks is what the recommendations say, which is usually not when anesthesiologists see their patients. So that's why many adult hospitals have preoperative anemia programs, especially in the United States. There's a lot of work being done with some of my colleagues. Matt Warner of Mayo does a lot of work with preoperative anemia clinics for adults, but we just really haven't done that with pediatrics yet.
Well, that was my next question. Is there an equivalent in pediatrics? And it sounds like you're on the way to doing that in Boston if you're not there already, but what does the data show when you intervene with these iron and EPO supplements?
Boston Children's Hospital is going to be one of the first hospitals to have a patient blood management program. And one of the first kind of low-hanging fruits for me would be to start that preoperative anemia. I work with a couple of surgeons that are the craniofacial surgeons, and we've been collaborating that when they book the patient for surgery, that's when we send them for their iron studies and start treating them then. So I think if we can get a small win and show that it's reasonable results, especially if we make it easy for surgeons to help us manage these patients, we've got some good results already with that craniofacial group, and we hope to bring it to the wider population too. Adolescents coming for scoliosis surgery, another big group, especially the females. Very often, a lot of those are anemic, and it may not make a difference on length of stay or severe adverse outcomes, but just think it might make them feel better in the recovery if they're not anemic before or after surgery. So there's lots of work to be done.
So your talk, I think, is about the best recent papers in the area. Do you want to give us a preview about which ones you've chosen?
Oh, I was worried you were not going to ask me that. I did choose one of my own papers.
What a good idea. Why don't you tell us about that?
Because it was just recently published in British Journal of Anesthesia, and we are presenting it here at this meeting as a poster with one of my junior colleagues.
Fantastic.
It is looking at the large NSQIP retrospective database, and what we did was we looked at the incidence and prevalence of anemia, transfusions, and outcomes in U.S. hospitals using the NSQIP database. In children. We looked over the last decade, and we found that over the last decade, the incidence of anemia is 25% in U.S. hospitals, and it's not changed. And over the last 10 years, the incidence of transfusion, at least within that database that we're using, is 7%, and that has not changed. And the mortality, there's an independent increased morbidity and mortality in patients who are anemic, patients who are anemic and get blood transfusions. And the highest is with the combination of both. Anemia and blood transfusions has the highest adverse events and independent associated mortality risk in that group. So it's something I think to wonder about if we lean on that first pillar and potentially manage anemia better, would that change the outcomes? We don't have that answer yet, but at least it's a thought-provoking independent association between anemia, transfusions, and increased morbidity and mortality.
Did you consider whether anemia and transfusion are actually sort of mediators or indicators of another process that's leading to a bad outcome?
I think it's a great question, and I think that's the sort of limitations that you have with that kind of a study and looking at retrospective data, is that there's definitely going to be confounders. And so is anemia a marker for higher risk? A patient might be sicker and therefore anemic or in hospital longer, and so it's hard to really tease that out. That's why we need more work and more prospective studies on it.
And do you have any other papers that you would like to tell us about?
One of the papers that was published in BJ Open, which, little bias, I'm now the editor-in-chief of British Journal of Anesthesia Open, and we're getting an impact factor soon, so that's exciting. So I wanted to showcase a paper that was recently published this last year, and it's looking at key performance indicators, because really, if you don't measure it, you didn't do it. So we can do a lot of work. We've only just talked about the first pillar. We haven't even talked about the intraoperative management, patient blood management, or the postoperative patient blood management. But if you do all of these great blood conservation strategies, for your patients, and you don't measure it, then you really didn't do it. So the paper that I'm highlighting in BJ Open is from a European group, and they're looking at key performance indicators for red blood cell transfusion. And they did a Delphi consensus method where they reviewed all the data, they looked at all the studies, they came up with 28 key performance indicators, and they all had a consensus and voted for the most important ones, which are 9. And so, it hadn't been validated yet. So I think these key performance indicators are something that hospitals can take and then sort of follow the metrics. Some of those are incidence of transfusion in different surgeries, incidence of transfusion when the hemoglobin's at greater than 8, so potentially not indicated, incidence of overtransfusion, so that post-transfusion, if the hemoglobin's greater than 9.5, potentially overtransfusion. Was tranexamic acid used in a major surgery or not? Cell salvage, some of those blood conservation strategies. So some of those key performance indicators, I think, are good metrics to kind of look at the data and see where there's opportunities for improvement.
Fantastic. We'll put links to those 2 papers in the show notes, Andy.
Absolutely. You're right. We haven't yet talked about those other 2 pillars, but it sounds like from those key performance metrics, we should talk about them because a lot of them seem relevant to those other sections. Do you want to quickly summarize?
Yeah. So we talked about preoperatively, really having a patient blood management program is a good bringing together all the stakeholders to manage these patients and treating anemia. And then intraoperatively, it's probably all the things that a lot of us anesthesiologists are doing anyway, utilizing restrictive transfusion thresholds, giving antifibrinolytics when indicated, optimum blood use, which is really giving the right product to the right patient for the right time and the right reason. So avoiding overtransfusion, but patient-centered transfusion management, using algorithms, maybe point-of-care devices like viscoelastic testing. Those sorts of things all kind of come in. The biggest intraoperative patient blood management is really surgical hemostasis. There's nothing you can do if your surgeon makes a bloody mess. So you really need to work with your surgeons, because if the surgeon doesn't control blood loss in the field, good hemostasis, then all of your patient blood management modalities are kind of down the drain.
So following on from that point, particularly in adult practice in the UK, we've done a lot of work recently looking at the use of tranexamic acid, and it's interesting. Our surgical colleagues are mixed on, so some are very pro us giving TXA, and some are less keen because they think about perceived risks, whereas from the anaesthetic side, we're actually more keen to give it in the adult population in the UK. But is that the same in pediatrics? Are there any risks that we should be aware of? Or?
It's hard to change culture. And the only way you can change culture is with evidence. And so when I have, a discussion with my surgical colleagues, and I remember 10 years ago trying to introduce tranexamic acid into our craniofacial population, that's basically why I got interested in patient blood management and started to do the study, was that I was just worried that the patients were bleeding too much and wanted to do something. And I knew we used TXA in cardiac surgery. So, it's just really using evidence-based medicine to bring your surgeons on board. Yes, there are risks. Most of the risks are with giving large doses, so toxicity, which is seizures. And then everybody worries about thromboembolic events. I always say TXA is a clot stabilizer, not a clot promoter. And so it's going to be blamed if there's a clot, but it's really a clot stabilizer, not a clot promoter. Very many of our surgeons are not concerned, but we do present the evidence. We've done pharmacokinetic modeling to determine the appropriate dose. That's really what you need to do, is to give TXA using the doses recommended by pharmacokinetics to avoid overdose.
I think that's very well summarised and probably fits with what we've agreed in the UK as well, which is good to know. Just very quickly, we should touch on the postoperative pillar before we finish.
The post-op care of the patient's blood health is one of the biggest things that people don't think about at all. Patients are sent to the ICU or to the floor. One of the biggest things that happen is we call bleeding into the chart, which is iatrogenic blood loss. All of these routine blood samples in the ICU 3 or 4 times a day, we'll check and check and check and check, and it's low, we better check again. All of that is just wasting a patient's valuable resource. So keeping the blood in the patient postoperatively is just as important as intraoperatively, and avoiding bleeding into the chart, avoiding unnecessary blood work. And then, in pediatrics, we have small tubes, small samples, that sorts of things. We have ways to give the blood back, to not take 3 or 4 cc's and throw it in the bin. So iatrogenic blood loss is a big thing postoperatively. Treating that patient for anemia, non-transfusion wise, just keeping the iron going and helping to boost the red blood cell mass is important. And then, tolerating a low hemoglobin if the patient's, and using the physiological signs and symptoms that we get from our patient instead of treating a number. So treat the patient, not the number. And some, I think, important things to think about postoperatively.
Excellent.
So what else are you looking forward to at the conference, Susan?
Well, the reason we come to the conference is to see our friends and colleagues. And for me, I'm just trying to get out and see as many people as I can, have some good conversations, kind of be in the moment. And, I've been to so many of these conferences that now I really value one-on-one time with people and talking and chatting to people. So I'm looking forward to social events.
Excellent.
Yes.
Thank you so much for coming on the podcast.
Thank you. Thank you for having me.
Always a pleasure. But so thank you very much, Susan. I've learned lots in this one, definitely, so thank you.
TopMedTalk.
You can hear this and all other episodes on our website. You'll find us, whether that's Apple Podcasts, Spotify, we're on all of them. We're on all the social media channels, so if you do find us on there, please do hit like, hit subscribe. We should thank our sponsors. So this year, that's BD, or formerly Edward Life Sciences, so BD Advanced Patient Monitoring, and GE Healthcare, without whom we couldn't keep TopMedTalk free and open access to the world. And of course, we should thank the ASA for having us at this fantastic meeting.
Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.